My lecture this afternoon is about monitoring directed management of traumatic brain injury. And if we look at the traumatic brain injury, there are several causes, and the treatment should be directed to those causes. But the most important thing is to prevent primarily it from happening, because the reason is the outcome is devastating because it's a leading cause of mortality and morbidity. And its severity very largely depends on the Glasgow scale. When it happens, there is primary and secondary injuries. The primary injury is actually what happened to the brain immediately after the insult. And we basically have nothing to do with this injury. And it involves axonal disruption, shear stress, brain laceration, vascular disruption. But the most important part that we have to play around is the secondary injury, which can happen due to edema, increased intracranial pressure, and then squashing of the blood vessels with ischemia and cerebral blood flow abnormalities and some metabolic derangement. And this illustrates how actually the secondary injury can induce further damage to the brain after the primary insult. The brain is unique. It's not like other organs. We cannot examine it directly. There is no auscultation, percussion, palpation, and most of the monitoring tools are unfortunately invasive. So we have some challenges to deal with these injuries. One of them is the three components of the brain, namely the brain tissue itself, the cerebral blood volume, and the CSF are enclosed in this bony skull. That's why any increase in one of the components will certainly increase the intracranial pressure. And we don't know whether our patient is at the flat portion of the pressure volume roof or the ICP compliance curve, or it's at the high part of it. We don't know that. Again, the pathology is very complex. Not all the parts of the injured brain are the same. Some are ischemic, some are hyperemic, some with inflammation, some without inflammation. And the consistent course, the patients may actually do well and then deteriorates. And actually, the global changes don't reflect the regional ones. So the global cerebral oxygenation doesn't actually tell me that all the regions inside the brain are well oxygenated. Also, it is influenced by systemic insults. So any derangement in the blood pressure, ventilation, oxygenation will certainly have an impact on the brain itself. Autoregulation impairment is another issue. It starts within the first 2 days of traumatic brain injury. And it varies from one patient to another. Not only that, it might vary actually in the same patient over time. And we can see that all of us have a certain range of autoregulation. And those who have hypertension have the rightward shift of autoregulation range. And for this ability within the normal range to control the cerebral blood flow over wide ranges of mean arterial pressure, we have to have an intact autoregulation. That's why we cannot treat patients with intact autoregulation as we do with those with impaired autoregulation. Here, one size doesn't fit all. Another challenge is that cerebral blood flow may not match cerebral metabolic rate. Whether there is coupling, both go in the same direction, or uncoupling. There is lot of flow and low metabolic rate, or there is reduced flow and increased demand and high metabolic rate. Also, deterioration in these patients can happen pretty fast, and that's why we need real-time diagnosis of the problem and intervention to deal with this problem. And unfortunately, no single monitor tool is reliable because, for example, if we need to know the brain tissue oxygenation, we cannot interpret it without knowing how much the cerebral blood flow is, how much oxygen delivered to the brain, and what is the cerebral metabolic rate is. That's why, actually, if we can manage the management of the TBI is as if we are managing in the darkness, complete darkness. We know nothing. And only monitoring directed management of TBI sheds some light on this and makes us able to know what's going on and how to do it. So what offers us this monitoring guided management? Allows early detection of secondary insults, helps decision making, guides therapy, and provides trends for the follow-up of our patients. If we look at the brain, it needs simply blood, oxygen, and intact metabolic engine. and the supply and demand ratio should be matching, or there is coupling. So what to monitor then? We have systemic indices to monitor, and we have cerebral indices to monitor. We'll start with the cerebral indices. In fact, there is crosstalk between both. So systemic indices can affect the cerebral indices and vice versa. If we look at the mean arterial pressure, it indicates the need for resuscitation if the patient is hypovolemic or vasodilated. We can calculate the cerebral perfusion pressure using this formula by the mean arterial pressure, and normally it should be more than 65 millimeters of mercury, or a systolic of more than 100 according to the Brain Trauma Foundation. We treat these fluids. However, we might need some vasopressors to improve the systolic or the mean blood pressure. And they found in this study that patients who received phenylephrine have higher mean arterial pressure and cerebral perfusion than those who use dopamine or norepinephrine. Another important point is when we measure the arterial blood pressure, directly by arterial cannula, we have to reference the transducer at the level of the foramen of Monroe rather than the heart as we do in other surgeries. Arterial oxygenation is very important because it determines how much oxygen is delivered to the patient, and this all we know that depends on cardiac output, arterial oxygen tension, hemoglobin, and also erythropoietin have been used to improve the oxygen delivery. However, this study in JAMA in 2014 showed that neither the administration of erythropoietin nor maintaining hemoglobin concentration of greater than 10 resulted in improved neurological outcome. One of the most important factors is CO2. We know that cerebrovascular activity largely depends on the CO2. Hypocapnia causes cerebral vasoconstriction, and hypercapnia does the opposite. And there is a very interesting article by Professor Adrian Gelb in anesthesiology 2 years ago about regulation of cerebral autoregulation by carbon dioxide. And I encourage you to read this review article. Another this is systemic indices. What about cerebral indices? This question is what index to monitor in the cerebral indices, and what target, and also what is the evidence, if there is any evidence to support using these monitors. We'll start with the cerebral blood flow. Cerebral blood flow, how to manipulate it. We can actually measure it by transcranial Doppler, laser Doppler flowmetry, near-infrared spectrometry, and thermal diffusion flowmetry. And this table shows the different actually types of monitors, either one-shot snapshot monitor or continuous monitoring of cerebral blood flow. When we look at this figure, we can see here the CT on the left side and the xenon CT on the right side. If we look at this area 16, 17, 18, this is where there is brain edema. And we can see actually there is middle line shift. And on the xenon CT, you can reduce cerebral blood flow at the same area. On the other side, there is a counter coup, and we can see the injury and the brain edema. On the xenon CT, you can see also a reduced blood flow on the same side. How can we manipulate it? We have to have targeted therapy. And these targeted therapy are ICP, cerebral perfusion pressure, and cerebral autoregulation. When we use ICP alone, that was the Lund concept, to reduce the intracranial pressure and therefore increase the cerebral blood flow going to the brain. The cerebral perfusion pressure is the Rosner one. Regardless of the edematous of the brain, we shouldn't worry about ICP. We just squeeze more blood into the swollen brain. And none of those are actually valid. The important was the ICP-CP target therapy, just put forth by the Brain Trauma Foundation in 2007, and we'll talk about this. Last year, the Brain Trauma Foundation guidelines actually showed that the ICP should be less than 20, shouldn't be more than 20, CPP not more than 70 at all, because pushing it higher than this can expose the patient to pulmonary edema and fluid overload, and it should never be below 50 millimeters of mercury. So we'll start with the ICP. Is there any evidence to support that using ICP will help in managing those patients? If we look at this picture, it shows how can we monitor ICP. Intraventricular catheter is the gold standard, but we can use still subarachnoid intraducer. Intraparenchymal now is very widely used because you just make a burr hole at the intensive care bed, put a three-way burr hole bolt, and you can measure through this bolt so many things, including intracranial pressure, brain tissue oxygenation, and brain temperature. So initially the evidence was a bit contradicting. Some said that it improves outcome, some said there is no benefit. In the Journal of Surgery 2015, they found that there is found no evidence to indicate that ICP monitoring overall is significantly superior to no ICP, so no benefit. However, in last year, this study actually looked at the impact of intracranial pressure monitoring on prognosis of patients with severe traumatic brain injury, and they stated that ICP monitoring may not reduce the risk of hospital stay, but plays a role in decreasing the rate of electrolyte disturbance, renal failure, and increasing favorable functional outcome. In another study last year, they looked at the effect of intracranial pressure monitoring on mortality in patients with severe traumatic brain injury, and that was a meta-analysis, and they found that ICP monitoring superior survival was observed in those who had ICP monitoring. The Brain Trauma Foundation, the latest one, guidelines, they found no class 1 or 2 evidence to support using ICP. However, there was class level 2B evidence saying that management of severity the traumatic brain injury patients using information from ICP monitoring is recommended to reduce in-hospital stay within the 2 weeks, mortality. So this is ICP. What about cerebral perfusion pressure? Again, the recommendations from Brain Trauma Foundation is that there is no level 1 or 2 evidence, but there is a level 2 evidence to recommend target CBB between 60 and 70 millimeter mercury. And again, they refuse to push it further than 70. There is an important recommendation here, which is actually underlined. Whether 60 or 70 millimeters of mercury is unclear, and this will depend only on the patient's individual autoregulation, and we'll come to this in a moment. So this is actually the highest and the lowest limits of the autoregulation. We shouldn't go below 60, we shouldn't go above 70, and this is but for a given patient, let's ask ourselves, for a given patient, is this range of cerebral perfusion pressure, is the optimal CPP? Is it the CPP at which or below which ischemia happens? And does it ensure adequate cerebral blood flow at every patient? In fact, one size doesn't fit all, and the optimal CPP 60 is unclear and may depend upon the patient's autoregulatory status that takes us to measure something different to make sure that the optimal CPP is achieved. That is cerebral autoregulation. And if we look at this article in BGA in 2013, they found that one should consider monitoring cerebrovascular reactivity, which is basically cerebral autoregulation, as it might have profound implications in the monitoring and management of CPP. How can we measure it? It can be measured by examining the flow waves of the ICP and arterial blood pressure, and also by the wavelet analysis, which has been proved in this study this year that it is more advantageous to the traditional cerebrovascular pressure reactivity index. This study in critical care in 2012, they looked at continuous determination of optimal cerebral perfusion pressure in traumatic brain injury. So they measured the optimal CPP, and they said that deviation from individualized optimum CPP were more predictive of outcome than deviation from a common target CPP, which is put forth by Brain Trauma Foundation as 60 to 70. And in another study, the same study actually found another conclusion that this wavelet cerebrovascular activity has a stronger relationship with patient outcome. So we shouldn't be puzzled by what I said in the last few slides. Let's make it a bit more clear. And if we look, do we have to monitor ICP? Yes, the answer is. Manipulated? Yes. By ICP? Cerebral blood flow. Monitor cerebral blood flow? Yes. Manipulated by ICP? Actually, yes, but though there is no level 1. By monitoring cerebral perfusion pressure? Yes, but we have to individualize it to get this optimum cerebral perfusion pressure. By monitoring cerebral autoregulation? Yes, because this is the only way to measure the optimal CPP, by measuring cerebrovascular reactivity. Now we can ensure that the cerebral blood flow is optimal to the patient. Does it carry enough oxygen? So cerebral oxygenation is another parameter that we need to monitor. whether actually ICP, CPP, and cerebral blood flow is optimal, this is only the tip of the iceberg. But the most important is the brain tissue oxygenation itself. And we can measure this globally within the whole brain region by the jugular bulb oximetry, but regionally it might differ. That's why we can use near-infrared spectroscopy or brain tissue oxygen tension. I said that we can put a poultice screw, measure ICP, and also we can put a miniature Clark electrode through this burr hole and measure brain tissue injury directly. And this, as you can see, the brain tissue oxygen sensor, and we can put it at the area of focal injury or away from the area of lesion. And if the normal is 30, critical is less than 20, and ischemia happens if there's less than 15 millimeters mercury of oxygen. Does it improve outcome? Journal of Surgery 2009 concluded that the control of ICP with brain tissue oxygen directed protocol reduced mortality after TBI and resulted in improved 6 months clinical outcomes. Also, in neurocritical care in 2011, they concluded that brain tissue oxygenation may be an important therapeutic target after severe TBI, and it is superior to jugular venous saturation. And this study this year in the World Neurosurgery, it has a meta-analysis that showed that compared with standard ICP, CPP guided therapy, if we put with them ICP, CPP, and brain oxygen tension, the outcome is improved. And this algorithm tells us actually how to work. That was put forward by Sandy and his colleagues about if we have elevated ICP, low cerebral blood flow, or low oxygen tension. Now we go to the injury. We have blood, we have oxygenation, but does the brain can use it properly, or there is increased metabolism that actually make it uncoupled? Cerebral metabolism is one of the factors that should be measured, and the supply demand is determined by cerebral blood flow, oxygen, and glucose on the supply side, demand side, pyrexia, seizures, and mitochondria integrity. Cerebral microdialysis is another way. We just through the same burr hole, we can put another small semi-membrane, which actually we inject some saline, 0.3 milliliter, and leave it for some time, aspirate, and then we can actually analyze dialysate to can measure substrates like glucose, metabolites like lactate, pyruvate, neurotransmitters, and neurochemicals. And one of the most important derivatives is the lactate oxygen index, lactate pyruvate ratio, and the glycerol, which is a marker of cerebral cell damage. If we look at this graph, on the right side, this is the cerebral microdialysis oxygen level, glucose level. On the right side, this is the blood glucose level. On the left side, we can see that the cerebral microdialysis glucose level is less than 1 millimole, because this is hypoglycemia, whereas the blood is 4. So what they did, they injected some 10% dextrose, and you can see how the increase in cerebral microdialysis glucose is. Cerebral microdialysis can improve outcome, and in this study, a systematic review published this year, they concluded that the evaluation of cerebral microdialysis and CSF psychoanalysis is an emerging area of the literature in severe TBI, but they need more. At the current state, it is an investigatory tool and research tool. It's not widely actually adopted in many neurocritical care units. Cerebral imaging can also be used to detect metabolic derangements, and if you look at this figure, sorry, there is no pointer, the CT on the left side and the other side is the PET scan. We can see here that where the problem is on the left hemisphere, there is brain edema with some red line shift. If we look at the cerebral blood flow in the first xenon scan, there is a reduced cerebral blood flow. The second one going to the right, there is less cerebral metabolic rate of oxygen, where the last right one, there is increased glucose because it hasn't been used because of the cerebral problem. Cerebral temperature is another thing that we need to look at. Do we need to measure it directly, or we can rely on the core temperature? Actually, core temperature does not at all reflect brain temperature. Brain temperature is normally 0.5 to 1 degrees Celsius higher than the core. The white matter is higher than the cortex. Injured brain normally has 1 to 4 degrees Celsius more than the core, and in the difference goes even higher if the temperature of the core temperature is more than 38 degrees Celsius. And if we look at this study about brain temperature, body core temperature, we can see the difference in between the two, and the conclusion was that intracranial temperature is significantly higher than core temperature, and that core temperature may underestimate intracranial temperature. So in that case, someone might argue, do we need therapeutic hypothermia? Does it help in patients who actually have traumatic brain injury? Again, the evidence was conflicting, and this study in 2010 published in the BGA, they found that therapeutic hypothermia was associated with cerebrovascular disturbances, on rewarming, and possibly with pneumonia in adults, and no benefit of therapeutic hypothermia on mortality or neurological morbidity. However, in critical care, in 2014, there was a systematic review that concluded that in contrast to previous reviews, we found some evidence to suggest that therapeutic hypothermia may be of benefit for treatment of traumatic brain injury. The recommendation of the Brain Trauma Foundation came out on 2016, and they again found no level 1 or 2 evidence, but level 2B that even short-term, early therapeutic hypothermia is not recommended. However, a bit later, 2017, there is this meta-analysis published in Critical Care that actually put some more hope on therapeutic hypothermia use, and they said that it is likely a beneficial treatment following traumatic brain injury in adults. So the jury is not there yet to tell us whether to use therapeutic hypothermia or not. Cerebral electrical activity again. Each seizure, as if you are hammering the brain without the skull, it's really happened. It happens in 1/3 of patients of TBI. It can cause secondary injury. It's very much associated with poor outcome. We can measure it by direct normal EEG, but it's a bit cumbersome to analyze, but the processed EEG can help. It can tell us if there is seizure activity, especially in patients who are paralyzed, or it can show us actually the effect of therapy if we want to achieve Boris suppression. The Brain Trauma Foundation guidelines, again, there is no one level evidence, but there is 2A level in this time that still, like the previous reports, we should not recommend prophylactic use of phenytoin or valproate. However, they actually put the door a little bit open, saying that phenytoin is recommended early within 7 days if the benefit outweighs the complication of using the anticonvulsant. Again, this cerebral metabolic rate guided therapy, algorithm, so it tells us what to do if the low blood glucose is there, or there is elevated lactate pyruvate ratio, or there is elevated brain temperature. So the take-home message in brief is that there is no class 1 evidence to tell us how to intervene in these cases. But however, there is evidence that cerebral autoregulation and brain tissue oxygenation monitoring can identify optimal CPP targets. And also, we have to use multimodal monitoring, because there is no single monitor that can tell us what's going on in the brain or what to do. And more importantly, we have to individualize these. We shouldn't be using target ranges because everyone behaves in a different way. That's another most important take-home message, is that it is not the monitor, it is the man behind the monitor actually who can interpret the findings or the recorded data from the monitoring and interpret it in the correct way and actually intervene in the appropriate way. One more important take-home message is, as I said, the changes can be rapidly detrimental. That's why we have to diagnose it in the appropriate time and to intervene in the right time. Thank you so much.
Thank you, Professor Mohamed.